a nice amount of people here, so we could get rolling. My parents are here. Dr. Rizé is here. Nice haircut. Yep. My hair. When you don't have a lot of hair in your head, when it gets really long, it just looks worse and worse. So my wife, we had some clippers in the house, and didn't really have any adjustments, so we just took it off. My wife cut my hair. Yep. You got to do what you got to do. You got to make do. There's the COVID haircut. We're all part of it. All right. So let's a couple things I wanted to touch on, and I was just taking some notes earlier today. Let me just pull them up. Okay. So really, I have some basic background, some basic things that I've been thinking about. Some are a little concerning, but I think some are will be very informative. And a lot of this is basically extrapolating our current situation, and how do we take what we know and apply it to the future. And that's always something that is so difficult to do, right? Obviously we can't predict the future, but how do we understand what are some potential pathways of what the future is going to look like. And so I've been spending the last couple of days thinking hard about that. And personally, I could tell you that I go through periods of optimism, and then really probably more pragmatism than pessimism than anything else. I think I'm naturally an optimistic person. So that pragmatism, though, sometimes gives you a good gut kick, and it's hard to wrestle with sometimes. It's a good thing we have the best wrestling coach on the East Coast, Mike Russo, on this call to help us with anything there. All right, so here's kind of the deal with what I'm thinking about right now. And, this past week we saw in Michigan and many other states, Ohio, Texas, it's really kind of nationwide. Whether or not this is politically motivated, probably is, but there's a lot of people who are angry. There's a lot of people who want to kind of get back out in our economy and get things started again. And look, that's understandable as far as people feeling that way. But one of the things that's so critical right now is that we have collective buy-in to what's happening. And we saw what happened back in January and February when people weren't taking COVID-19 seriously. And it's now led to, the number of deaths in the United States from this will pale into comparison to any, we're at the levels of the Vietnam War right now, of the number of people died. And you think about, that was a decade worth of fighting. And here we are. And this, unfortunately, is still going to be a very small number compared to what it's going to look like when we come out of this. So we need a collective responsibility here. And unfortunately, we're not there yet. And because we're not there, we're going to see, unnecessary infections. We're going to see a rise of infections. We're going to see unnecessary deaths as well from all of this. And what's really important is that we look at this as an us versus the virus. All right. This is humankind versus the virus. The virus doesn't care about anything else as far as it just wants a host to live in and replicate. That's it. Now, I don't want to think that, I'm not confusing this with the need to be able to get out, start up the economy, get businesses going. That is so critical, right? And I've said this before. We have to get this economy started for various reasons. And, one of those main reasons is because we need to support what I want to consider what I want to call a COVID ready state. And that means, right, we need the necessary tools and supplies to do testing. We need the tools and supplies to provide medical care. We need sustenance. We need food. We need stores to be stocked. We need things delivered to us. And that's not going to happen on its own, right? We need people to get out into the economy and help manufacture and provide these services, right? That's clear. But what I feel like some of this current climate is, it's one or the other, and that is far from the truth. They're not mutually exclusive, right? We need to do both. So what I'm not hearing the talk right now, there's so much talk about getting out into the public, and then there's so much talk about staying, shelter in place. But we're doing very little talking about COVID ready state, a COVID ready state. And what does that look like? All right. Because ultimately, eventually this will catch on, and eventually this will be what we do. Because if you hear the news out of Germany, Czech Republic, Austria, and many other countries that shelter in place early and are now opening up their economies. The reason why they're opening up their economies is because they're confident in their internal system, their domestic system that they have in place, so that they're going to be able to identify when cases start to rise again. And this is going to be so critical. If anyone thinks on this call here, and please spread this word, that we're just going to experience a big uptick in infections and then it's just going to kind of fizzle out, that is extremely unlikely to be the case. What we're going to see here is this uptick, okay? And we don't know when, depending on our behavior, we're going to get another uptick, and then we're going to get another uptick, okay? How the amplitude of those upticks and the frequency of those upticks is all going to depend on really two main factors. Factor one is, are we abiding by physical distancing, good hygiene, mask wearing, all right? Things that we should all know about. And number two, it's what has the system put in place? What has the governments, the townships, the country put into place so that we could identify those who are positive or negative of COVID-19. We could provide contact tracing so that we could isolate or quarantine contacts, and that we could provide support for people who are now positive, and we could keep them out of society. So we're going to continue to see pockets of explosive infectivity, and that's expected. What is so critical is that we're able to compartmentalize that, so we're able to limit any of that spread once it happens. Now, think about this. I was thinking about this today, and the U.S. government, and I know very little about this, but it's just a mental model here, right? You've heard of NORAD. It's like where the government has a base station, an air station that tracks incoming missiles and flights and things like that. I know after 9/11, big cities put in radiation detectors around the city so that if there was ever a radioactive dirty bomb or anything like that, these Geiger counters would detect radioactivity, and it would give an alert that, hey, something's going on here that we may not be seeing. This is the same type of thinking that we need for COVID-19. We need these detectors spread around different cities and different communities so that the minute we see an uptick, right, we're able to impose a shelter in place on a community again. So instead of doing this for an entire county or an entire state or an entire region, we're able to operate in a way that shelter in places the hot spots, all right? And this will allow us to try and you know, do whatever we can to get parts of the country, parts of your state and regions to get back to some manufacturing, because you have to have that as well. So hopefully some of that makes sense here. And it's just kind of what I'm really concerned about is um, there's not, that needs to be the talk right now. Kind of the 80% of the talk needs to be about putting in systems like that. You know, I did get a text message today from the local pharmacy saying that they're doing diagnostic testing, which is good. Okay. But this needs to be done in a coordinated fashion. And what's really a letdown right now, and I know we're going to get past, I know this will change, but a letdown right now is that there is better surveillance, there is better public health measures during an outbreak of Ebola in Africa than we have here in the United States. Okay, meaning we send our own public health authorities in the world, you know, and people come together during the Ebola outbreak not too long ago and did testing and surveillance. Now, this is a little harder to do because it's a respiratory virus, but the approach that we're going to need here is to have a system in place like this. We are not talking about just a few months of this, guys. Okay. And what I say certainly could change, right? The only certainty I know is that there is no certainty here, right? We have a lot of unknowns and we're learning so much more as things go on, but we are I'm confidently thinking that this is 1 to 2 years that we're dealing with COVID-19. Okay. It's probably infected about 5% of the population, give or take, right? Maybe even more, give or take. And we're not going to start seeing a real impact of the slowing of infections from from herd immunity up until we get about 60 or 70% of our population being infected. And that's a long way off, believe it or not. We have this huge spike that just happened and it's on its way down. And it's on its way down because of physical distancing and sheltering in place. But, you know, so we just had a month, 6 weeks of this, and we have 5% of the population infected, give or take, right? Those numbers are unknown. So play this out, right? We need to get to 60, 70% of infectivity before we get any real herd immunity here. Vaccines, you know, in my mind, yes, that is a savior if we could get an effective vaccine. And that's a big, big if. And when that comes out, and I know you guys, a lot of people have questions about that, and no one knows the answer. I mean, things are happening with it, you know, but you know, I don't have enough information to say it's 12 months away or 2 years away. So hopefully there's a few important things there. We see that some of the countries in East Asia that originally attacked this very aggressively opened up, right? They opened up. A place like Singapore. You saw a video and photos of Singapore, and now they're dealing with another upsurge of cases. And this is what we're all going to have to deal with. We're going to have to adjust our mindset so that we will have we will go back out in society, and we could talk about, you know, we've talked about, and we could talk more about it, what that looks like. But then we're going to get an uptick in cases again, and we're going to have to come back in. We're going to go out, we're going to come back in. And this is, I think, probably in my mind, 80% of the probability of happening. That this is what's going to happen. And again, the frequency of those and the amplitude of those depends on what systems we have in place. I do think the workplace needs to adjust right now. And what do I mean by that? So places where people will be able to return to work need to start thinking about having, for example, 2 shifts or multiple shifts, right? So we take the model of how do you disperse people? How do you dilute a workforce So maybe instead of working 8 to 5 or 9 to 5, people are working, 7 to 1, 9 to, whatever, 3, 2 to 7, and you start diluting your workforce. That's going to be something that's going to be useful. Lunchrooms or cafeterias, right, where people normally congregate to talk, need to be dispersed and spread out. So you could do that by staggering lunch hours as well. No more water cooler talks, right? Everyone should be wearing masks who are going to work in the same office. There may need to be separation of, not may need to be, there needs to be separation of desks, right? People need to be spaced apart. So these are some of the measures that the sooner we implement as a workforce, as business leaders and people in schools and any place where people come together, the better off we're going to be as a society. And this is where buy-in from everyone has to come in, right? If 50% of us are doing this, it's still not going to have the impact it needs to keep us all safe and slow things down. And so we all have that responsibility. Just looking at a few other notes I took here, and then I'll go and answer questions. I think that's it. Oh, one thing I was thinking about is, it's funny here in the United States. It's funny that, like wearing masks, traditionally, right, we would typically see people of East Asian descent, or when you go out to East Asia, mainly China, Japan, Southeast Asian countries, people would be wearing masks. It was pretty, built into their societies. And here in America, I think, right, it was natural for people, because of inherent biases, that we would kind of look at that and be like, oh, that's interesting. Why are they doing that? And so when COVID first started, I think people are very uncomfortable wearing masks out in public. I know I certainly was, right? And going into a store where you're the only one. I had worn a mask very early on, and it's like you're the only person on a plane, let's say, wearing a mask. It feels awkward. What's going to change is a mask is going to be a status symbol, right? It's going to be a symbol in that I am bought in to what we need to do as a society to get past, to get through COVID-19, right? So the more people who are wearing the masks, that's going to be a show of commitment. That's going to be a show of, I'm in this, and I need to do the right thing here. Okay, so think about the mask in that way. All right, I think that was a good amount of background, about 20 minutes of talking. So I'm going to dive into some of these questions here. And all right, let's see here. And feel free to comment, to add whatever you want. Still going. Yeah, exactly, Dana Green. Kevin James will be happy. I was thinking about him. Am I wearing pants right now? I am wearing pants, but they're like old jeans that I paint in. All right. Mike Russo, you bet, man. Glad to have you on. Megan, Kelly Pape, Julian, good to see you. High five. Cousin Jody, good to see you. Salim, in areas of lower prevalence of disease, may be worth trying a soft opening with young people who are at less risk of bad infection. Absolutely. So Salim brings up a great point, right? We can't treat everything equal when we're opening up, right? So we know places like New York City, New Orleans, Detroit, like these are hot spots. And we know that if people kind of go back out there, this is gonna tick back up very quickly. But there are areas that have lower densities, lower infectivity rates, and we also know that in general, younger people have lower mortality. We believe that's the case right now, and we do have the ability to test people for a robust immune response. And so, ideally, right, as part of a federal national plan, and states could be doing this as well. You take areas that meet these criteria where you could get young people, ideally who are immune, and in low density areas, like get them out there. And we've touched on this before, that the more people who are out in public who have an immune response, a strong immune response, they act as lightning rods for the infection, meaning they're going to slow down the rate of infection. So that is absolutely part of this plan. And I'm not sure I just hear enough people talking about it in a coordinated way, right? It's almost, I mean, it's crazy, to be honest with you. There's no like, centralized plan that people could roll out, and when the states are doing it, I don't know, they'll eventually learn what they need to do. But it's just like, how long do some of these places need to wait to do it? So my sister Felicia on. Hello, hello. Stu Wexler. By the way, I think if you haven't read Stu's book, look him up. Amazon, Stu Wexler, Jersey guy, history, politics. So isn't it the case that given how debilitating even mild experiences are, that the economy is going to be impacted anyway? Flu would keep someone out 2 to 3 days. This looks like 2 to 3 weeks. No, there's no, look, right? There's elements of the flu that are like this, right? It's a respiratory disease. The economy will be in shell shock a long time. The economy is not coming back in 2 weeks or 2 months. We'll be lucky if it's back at 2 years. This is a very significant change to our life right now, and we need to live it differently than how we lived in 2019 and early 2020. We don't stop living, right? We don't give up. We don't just stay indoors and do nothing. We need to find what is our new life? What is our new way that we're going to live? Probably taking 80% of what we're used to, but maybe 20% new stuff or 40% new stuff, whatever it may be. We need to create that new normal for us. And the sooner we do that, the better off we're going to be mentally, for sure. The better off our economy is going to do as well. So there's no better time right now than to actually create digital products, right? So that's a good tip. Okay, Dana Green Witter, wouldn't it make sense to systematically stagger the amount of people allowed at certain places? Absolutely, right? I think that makes intuitive sense to us. So, the less people who are together, the lower concentration, the better we're going to be. Professor Guitre, tenured professor, Egyptology. This opening statement you are making is exactly what's been on my mind. Excellent. I know that I am in good company then. Kevin James, if we do too much too soon, then wasn't this all for nothing? No, this wasn't all for nothing, because we had to, this was a wave that just came crashing down on us. And the quicker and more robust that we reacted to it, the more people were going to survive. Okay. And overall, we did a decent job. Okay. It could have been a lot worse. And so, right, that impact was already made. That's done. That's in the past. I mean, we're coming down from this, right? So it's what's going to happen in the future, because we could see scenarios, and it's so hard to think about what, here's a good way to think about this. Think about what life was like 1 month ago. Think about what life was like 1 month before that. What was February like for you? Okay. Go through your calendar. And your mindset. What was March like for you? What was April like? All right. It's changed significantly each month. And now try and think about, what is October going to be like? right? It's so hard to do. It's so hard to know. And so we think that this has been so challenging. This has been so challenging for us, but there's a potential where you can have another wave that's even worse than this, or you can have it where it's not, right? Where it's 50% at this intensity. We just don't know. It's all dependent on how we go about reemerging into society. Christy Conti, struggling to understand how long someone is asymptomatic but can still pass on the virus versus having antibodies. When can families get back together? When can kids who seem to be on the asymptomatic side at a much higher percentage see grandparents? So this is I can't speculate. I can't give dates or speculate on any of this. I don't want to do that. I don't want to set any target or anything like that. This is a really, really, really difficult issue. Immunity to this it's not perfect, right? We don't know for sure, but let's presume that traditional virology holds and people who mount a robust immune response measured by serum antibodies are immune, that they're not going to be reinfected. And also, I think infectivity, I think if you have robust antibody response, it's probably unlikely that you're infective. Now, there's still a lot of debate going on. There's information about, people who are still testing positive, who have antibodies. And I don't want to get into that too much right here because it's changing all the time. And I'm going to go with basic biology, virology right now, and just say if I have strong, robust antibodies, I am immune and I'm probably not spreading the virus. But that's not 100%. So at some point after that, shortly after that, it would probably be safe if you're the person to go out into the workforce and to reemerge and to be able to see people. So where can you go get serologic antibody testing right now? Locally, I know the hospital is doing it, but they're doing it for hospital employees. The other issue is the tests are still kind of being worked on as far as how good they are. And the last thing you want is to be told that you're immune and it was a false positive, meaning you're really not immune. That's the absolute worst thing that could happen. So that's a work in progress. And I would just say right now, give it some time. Okay. We saw how much progress was made in 1 month. Let's see what happens in the next month. Okay. Part of this is being extremely patient and seeing where this goes. And I am pretty confident that within a month, right, we will have a much different environment that we're in right now. Phyllis St. Michael, what does another uptick in cases look like? I think I addressed that. Christy Connie, what about high-rise work environments, elevators, bathrooms? Yeah, so that's really good, right? So elevators now, probably you'll have a line. You'll be spaced 6 feet apart. One person will be in a small elevator at a time, maybe two. It just depends. It depends. But everyone should be wearing masks. And you should be spaced out 5 feet apart in elevators. Absolutely. Same thing with bathrooms. And this is the burden or the responsibility is going to fall on employers, okay? That they're going to need to set the right tone and be responsible here. Harriet Siegel Brown, what about states that are opening up gyms and nail salons, beaches? Isn't that much too soon? Yeah, I think I covered a lot of this, and I could give personal opinions on this, but it doesn't change what's actually happening and what needs to happen. So people are going to do, states are going to take. You heard what I felt is the right approach here. All right, if families have been isolating and quarantining, and no one has had any symptoms whatsoever, is it okay to see just our parents from a distance? Us parents with young kids who just want to visit with grandparents outside of distancing. So yeah, I think absolutely it's totally, and I think I actually encourage it. I think if you've been, pretty much physically distanced, you haven't been in areas of a lot of people, grocery stores, And ideally, if you had a mask, that would be even better. Go up and see someone that's, stay your 6 feet apart and have your conversation and see them in person. I'm all right with that personally, and I think you have to use your best judgment. The ideal situation would be, if someone has serologic antibodies, they would have diagnostic testing, but void of that, I would, I think it's fine, right? You just want to be smart and use common sense and stay your distance and ideally have some type of barrier. That would be wonderful. Erica Parrish, good to see you. All right. Kevin James, gotcha. Kristen Gargano, hello. Andy Reese. By the way, let me just say, if you guys aren't listening to the podcast that we started called Conversations with Rosh Review, I encourage you to do it. I just interviewed Andrew Reese. We're in the editing process right now, and it was phenomenal. Okay, really great. So what do you think of reaction in Sweden? Where are they in relation to Denmark, Norway, Finland, their neighboring countries? So, I know Sweden was kind of under the radar for a while. They did things a little differently, and I think they were having some trouble with the way they did things. These countries they have different systems than we have here in the United States. We probably have a lot more differing opinions here. But what I think we should pay attention to is Denmark, Finland for sure. I think we should pay attention to Germany and Austria right now because they have clearly made the decision that they are in a COVID-ready state, that they feel like they have enough of the infrastructure in place that they will be able to identify an uptick of spread. So, right, here's the important thing. It's not that there's no one out there who believes if we go out, right, or if we can't stay in much longer. We just can't, right? We have to get things going. And so we know we're going to go out, but how can we do that in the most responsible way, right? And these countries out in Europe believe that they're ready, and so let's keep an eye on them because that's the stuff that we need to be doing. And by the way, if anyone needs a colonoscopy or has any GI procedure in New Jersey, look up Dr. Matthew Grossman, and he's on this call. So hello here. 2 fellowships. He does stuff that you couldn't even dream up of. All right, Matthew Grossman. Adam, do you feel that the CDC has recommended that we use substandard masks due to the shortage in the healthcare world? Shouldn't we be using KN95s to maximize protection? So masks are going to, I touched on this at the very beginning, masks are going to be with us for probably years to 2 years. And if we are going to have any semblance of group gatherings, we're going to need a mask. KN95 masks supposedly are very good masks. Ideally, healthcare workers in the United States should be wearing the FDA-approved N95 masks that are well fitted around the nose, that create a seal around the mouth, and they're constructed with proper material. And we've spoken about that, right? Very different from a scarf. N95 masks are N95 masks, but made in China. So they may have a few different, standards, but they are being used in healthcare facilities. I've seen them. I know people who are wearing them, and I do think it's a really great alternative. And they are more available right now. And this is actually what I meant to bring up. There are a few places that I've seen starting to sell these masks, and I think it's important that healthcare providers they need priority on these masks, okay? As long as healthcare providers have access to enough masks, I think the public should start investing in purchasing masks as well. And I'm not talking like one mask or 2 masks here, right? We're going to be needing masks for the future for months and months and months. There is, if you look online, stadiummasks.com. I believe that they have masks. I put an order in with them. I got a notification that the order shipment is on the way. So we'll see how that turns out. But I bought something like, I don't know, a few hundred of these, and I'm going to take them and then disperse them out to family and friends, people around the neighborhood, so that we could maybe do things like meet with a family member. Okay, so hopefully that answered your question. Christy Connie, in the past, you have mentioned not wearing a mask when out. Is it time? Also, still okay to not wear one if you can avoid social distance? Right. So I don't think you need a mask if you're just walking around, outside on a walk. Like, if you want to be, if you're in the highest risk category, I think that's totally reasonable. But if you're going to meet up, if you're going to go back to work, if you're going to go into a Starbucks, right? If you're going to go to the food store, if you're going to go to the library, let's say, to study, a computer lab to do work in, a classroom potentially, right? Those are the places that you're going to need masks. Okay, question. Do you guys know what blood type the virus is affecting more? All of them. All right. Matthew Grossman, sorry about being I don't want to get into the, sometimes feels like pseudoscience. It affects everyone. Matthew Grossman. Okay, yep, more mass stuff. So Randy, hello, Randy, good to see you. If anyone ever needs Spanish to English translation services, you will not find someone better than a Randy. Pacheco Salazar in Michigan. But given that we are now in a learning environment, a remote environment here, you could probably do it online too. Okay, her question. Hello, everyone. I see different drive-through test sites opened recently. How reliable are those tests, right? We're probably not going to know what test each site is using. And most of these tests, if you get a positive result, that's probably better information than getting a negative result, right? So if I'm told I'm COVID positive, it's probably more reliable than if I'm told I'm COVID negative. Now, I'm generalizing there, okay? But that's a good place to start. So if I'm told I have protective antibodies to COVID-19, I probably do, versus telling me, so let me leave it at that. So positive tests in this case should be better than a negative test, okay? All right. Elvis, can you touch on if, by the way, Elvis, can you touch on if hospitals really are or even allowed to put down COVID-19 as cause of death if they didn't even have it, and if they are getting additional funding, so this is, so I know where you're getting at here. I've seen some things online, and this is the stuff that's really, really unfortunate here, the politicization of these, and look, you could dislike me for these thoughts here, but these are all conspiracies. And if you get COVID and you die of a heart attack, right, you're immediate, right, the COVID is most likely what caused you to tip over to have a heart attack, because the system is so impacted. But let's not even go into the weeds there, right? First of all, hospitals in the last month, now things are a little changed now, have been so overwhelmed, right? The fact that people have taken this thing about COVID-19 cause of death and have turned it into something is ridiculous. And they say it's about funding. First of all, hospitals are going broke, okay? William Beaumont Hospital, Michigan, just laid off 2,000 employees. Envision Healthcare will likely be filing. My guess is they will. They're in talks for restructuring. Healthcare facilities are going broke. Okay, so you want to, you want to support someone here, right? If you need, the government needs to do anything right now, it's to step in. And yeah, it's not to support a publicly traded company that owns these hospitals. It needs to support the salaries of healthcare providers. It needs to support public health measure. It needs to support public health. It needs to support medical research, right? It needs to support those things. All right. And every dollar that goes into that is pays dividends, right? It pays out so much more. And so when you go to the voting polls and when you the voting booths and you're gonna cast a ballot, think about everything that's just happened in the last 4 months. Okay. And think about how this started, and think about the language around COVID-19 when it started. Think about the language now, right? And think about the crazy, um, irrelevant arguments that people make. Maybe it's out of ignorance, maybe it's out of fear, all right? But this, if we want to be who we, our potential in the United States and the world, it's not a leap of faith to know that the more we invest in public health and medical science and research, the better we will be as a society. So I'll leave it at that. Raji Singh, I think this is Dr. Singh, who we went to medical school with. I think you're in New Jersey. I can't remember. But if you guys ever need a psychiatrist, look up Raji Singh. Adam, what's your projection with these southern states looking to open before they have even hit their peaks? This worries me. Like I say, I think, right, what we know is that the sooner you open into an environment that's not that you don't have a COVID ready state, and I don't mean state like United States. I mean a preparatory situation, a state of being. You're going to be worse off, right? So what matters is opening up. You need to do it in a very smart way so that the areas that have less cases should surely open. The areas that have younger populations should surely open. The areas that have higher immunity need to open. We have to open. There's no question. And so that's why I feel like instead of just saying, we have to open, let's get out there. Let's look at how we do that in a responsible way. So yes, it is worrisome what some states are doing, southern states in particular. New York, New Jersey, Michigan, California. A lot of these coastal states have done a really wonderful job with shelter in place, but it doesn't end there, right? It's really important that they take the next steps and implement a infrastructure to test, an infrastructure to allow people to get back out. Okay. Right, Matthew, Dr. Grossman. Yeah, antibody testing, it's unclear. And I'm not going to spend much more time on that with the antibody test. I think what we know now will change in 1 week, 2 weeks. Information is moving very, very fast. So, Christy Connie, how many times can you reuse KN95 mask? Does it depend on where you've? So, in the hospital, we used to use it, one for every patient and one per every shift. I think if we're using it just around personally, I would use. I don't know if there is a study actually. There is an article that I was reading, but I think. For example, I have one that I had when I was working, and one day I just took it home, and I still use it. It seems to work. I don't have a great answer. It's never gotten wet, but I would imagine that it probably degrades a little. I think N95 masks used to be 50 cents a mask. Now they're probably a few bucks a mask, right? I do think if you had, I think you should have, I think we all are going to need masks. Like, it's going to be part of our day to day. Like, we're going to kind of, at some point, maybe it's a week from, maybe it's a month from now, 6 months from now, I think before we leave to go out and to work, we're going to take our mask and put it on. It's like going into the hospital, right? I put on my name badge. It's the thing. It's going to be the same thing with a mask. You're going to take your mask, you're going to put it on, and you're going to go and get your cup of coffee or go to your restaurant. I think that's where we're going to be. Okay. Linda Lanky, I read the recent Science magazine article about how the virus attacks the body. That was a really good article. It talked about blood clots becoming a major factor in severity of COVID-19. Can you talk about this? Ultimately, we're still trying to figure out how this virus is what's the pathophysiology of this virus. It's new. It's literally a brand new virus, and humans have never been infected with it until recently. And so we have models of how these things infect. And there's some really, Rich Levitan wrote a great article today, op-ed piece in the New York Times. If you go to Rebel EM, he's been writing a lot about this. You go to Twitter, Facebook. But traditionally patients who were, we were calling this ARDS, right? Acute respiratory distress syndrome. The lungs are filling up, inflammation leads to fluid. And I'll keep this very general right now, that, oxygen levels drop, and right away you want to intubate or put a breathing tube in people, right? That's the natural instinct. That's what we've always done. But it may not be the case with COVID-19. And I'm not going to surmise what's right and what's wrong right now, because science works in the way that we need to continue to observe and test. And that's exactly what our best physicians and scientists and healthcare workers are doing right now. But there is a thought that and this is just what I've read in the article, and actually Salim, Rebel EM, is doing an interview. I saw that there's an interview with him and Rich Levitan, who wrote the article that I'm about to cite here. Right? The idea of hypoxia is low oxygen in your blood. Traditionally, when you have low oxygen in your blood, you also get high carbon dioxide. And believe it or not, the way our brain works, our breathing center works, is that we don't feel our urge to breathe faster. Our urge to take more oxygen in is actually driven by the levels of carbon dioxide. Okay. And so because COVID-19 is not impacting the level of carbon dioxide in in the exchange, it's the low, what we're seeing in the hospital is patients who have extremely low oxygen levels who feel okay, right? They don't feel, they're not sedate or tired. They're not extremely short of breath, in a sense. It's this really weird presentation. And so these patients ultimately don't necessarily need rapid intubation or breathing tubes that we normally would do for people like this. They need just a lot of oxygen and other medications and factors to limit what you've heard of the cytokine storm and the inflammation that's going on in the lungs. And there's some good information coming out about this, and we're going to have more of it in a week or two. And along those lines, this is looking more and more that, right, this virus is impacting the neurologic system. It's impacting our hematologic system, right? It's causing blood clots, and potentially if we know about this sooner, we could give a blood thinner. So the pathophysiology here is fascinating from the scientific standpoint. And I remember back, if you go, and I talked about this last week, right? The progression of HIV, right? Originally, it was thought to be like an HTLV1 virus. How does it attach? And we learned it's a retrovirus. And the point of this is that we will learn what's the issue here, right? We've done it with almost every other microorganism. We will learn. It's just going to take a little time for for our medical world to figure this out. But there is that article, Science Magazine article. Feel free to post it in these notes here. And it was a really good article. Peter McGrath, as a patient with ulcerative colitis, how do you think this pandemic will impact care for people with a chronic disease? I think it's going to be, everyone's going to be impacted in lots of ways. If you are using healthcare facilities, it's going to be more challenging to get access to them, I think. As far as you personally, anyone with any comorbidity or any other underlying disorder is at risk in general. But I think you continue to stay healthy, continue to maintain a relationship with your provider. Maybe you start doing things more through telemedicine so that you don't have to go into healthcare facilities. Use telemedicine. It's a great way to communicate and get most of your answers solved without being there in person. Danielle McGuire, by the way, if you guys have not read the book, At the Dark End of the Street, I urge you to go to Amazon.com and pick it up. Danielle McGuire is the author. It is a phenomenal read. All right. Does the death of a 5-year-old in Detroit change anything regarding COVID-19 and kids? Absolutely. So, we were talking about this. This should be international news right now. We know, adults, the older you are, the greater the mortality rate. In New York, you saw a lot of 20, 30, 40-year-olds. And here in Detroit, we just saw a 5-year-old die from this. And it was a case of, what's nuts about this is it was Maninjau Encephalitis. It was Maninjau Encephalitis. And so what that means is that this virus infected essentially the lining of the brain. And this is why this young girl died. And her name was, I wrote it down here, Skylar Herbert. It's totally so unfortunate. But, viruses do nasty things. Measles virus causes an encephalitis. Chickenpox virus causes an encephalitis. Viruses just don't, and they're also respiratory viruses. And does it mean that it's more virulent than we thought? Not necessarily. Does it mean it's spreading more than we thought? Not necessarily. But it does mean that our kids are not immune from the effects of it. And that resonates now through schools, right? Now, measles causes encephalitis, but there's a vaccine for measles, right? You get the vaccine, you're not worried about your kid at school getting measles. Same thing with chickenpox. I mean, now there's a vaccine. When most of us were around, we were at increased risk. And that's why the vaccine was created, so that we didn't come down with things like bad pneumonias and encephalitis. It's unfortunate, and I think it shows that we really need a vaccine for this. That is the only way around this. Okay, that's the only way that we're going to get through this. I shouldn't say the only way. It's the main way right now that we're going to get through this is a vaccine at some point where we could kind of let our guards down a little. Until then, we can't let our guards down, or potentially the virus mutates, or you get 80% of us infected, and it's like we've all been vaccinated. Okay. Who are the people who are planning how to safely start reopening in the ways you suggested at the start of this live talk? What should we everyday people be doing to encourage that sort of planning? I think that's going to be done at the state level, right? I think the governors of the states are the ones doing it, and they're probably, hopefully, working with the health authorities. I think different states are going to be doing it in different ways. I think locally, though, communities could receive some input, like the community center here in my area. They may want to know, how do you open up the library, right? How do you have cultural events? What about babysitting in a neighborhood? Things like that. Yeah, I would imagine that that's at the local level where you could have an impact for sure. All right, Daniel McGuire, also, can you talk about the California serology testing and its implication of higher infection, lower mortality rates? Well, anytime So I don't know enough about that, to be honest with you. I know you brought it up to me, and I haven't dug into it yet, so I can't comment that much on it. But you right here, what I could kind of infer is higher infection, lower mortality. Yeah, again, this goes to the number of tests that we've been doing. The more people we test, the better gauge we have of the mortality here. And so we're going to learn more every day. We're going to learn more. Dr. Singh, yep, in New Jersey, Gangadeep, that's right, is my official name, if anyone is in need. Thanks for your answer. Yep, Gangadeep Singh, it was phenomenal. I highly endorse if anyone ever needs psychiatric care in New Jersey. Okay, when might it be okay to resume? I hope soon for sure, but oh, uh-oh, I just went out. Can you guys see me? Okay, you guys are giving me the thumbs up. Good. That's weird, but my video is out. So as long as you can see, I'll just go into a black screen here. Okay, I'm going to keep going here. All right, thank you. Let's keep doing this. Um, so non-surgical procedures, absolutely. I think it's really important to get back out, and it's just all going to depend on the systems that we have in place here. So, you know, uh, offices, healthcare facility offices, are getting hit really hard economically, and people who could benefit from these procedures, there's non-essential procedures, but it's essential to someone. So I would love to see that happen. It just needs to be done appropriately. And that may mean, just depends. Like if you need a bunion removed on your foot, that's a much easier procedure than, let's say, a nasal polyp that you need removed, right? Because your nasal passage harbors the virus, and so you just need to put proper precautions in place. Okay, let's see here. Um, that's right. I know, Matt. I know, Doctor. Matt Grossman and I have been arguing since 2000. We studied together in medical school. I know it's not a retrovirus. I didn't say it was. I was just comparing the progress of it, of learning about it. It's an RNA virus. So he's a good friend of mine, by the way. All right. Gangadeep Singh, agree with telehealth. Yep, absolutely. Dana Green Witter, I can vouch for Dr. Singh. Oh, you guys know each other. That's excellent. Let me keep going here. Okay, my video. Okay, good. Thank you, guys. Thank you, everyone. So I'm just getting to the. Okay, cool. I'm just looking at a black screen. So, how are you feeling about dental treatment? I think that's a great question. And right, ideally, we have a situation where we know people's serology and we could do like rapid diagnostic testing. So imagine if we actually had a swab that we could do rapid testing for people who come into, let's say, a dental office. Now, just so you guys know, even if we had the ability to do that test, there are so many other things that are going to come into um, that are going to prevent this from happening anytime soon. And I touched on this, right? You need cotton swabs, you need reagents, you need plastics, you need all these things to get this stuff developed and done. And then you need the sheer number of kits. You need people to do this. You need training. So we're really far off from any of this. And I know when we get someone on TV who says everyone's going to be tested, that is not the case, and it hasn't been the case. we need everyone to be tested, but testing, we're not going to test ourselves out of COVID-19. There's so much more that's going to be part of this. But as far as the dental care goes, I think it would be neat is, if you could create some type of device that goes over someone's face and nose, and even potentially somehow limit saliva. And then obviously, right, you're going to be wearing a face mask, a shield. That's going to be required, a mask and a shield. And we're not talking about like a surgical mask here. I think anyone doing dentistry, dental cleaning, dentistry needs to be wearing N95 and also a face shield as well. Okay. Are you avoiding, David Caccarillo? Are you avoiding contacting the virus to flatten the curve? Are we avoiding contacting the virus to flatten the curve, but we'll likely eventually get this thing? Yeah, so, I don't know for sure, but most likely, right? I think it's safe to, I think it's, if I were to wager, and it doesn't help to do this, but just if we were all here, I would say, at least 40% of the population will be infected by COVID-19. I think just from sheer virology and infectious disease, that's what we're going to be looking at. I mean, easily 40%. Hopefully we get a virus sooner than that. A vaccine sooner than that. Hopefully we do that. But it was so critical to flatten the curve, and we may have to flatten it again, right? If we see a sharp spike, we're going to have to flatten again. Yeah, and that's, hopefully that answered your question, Caccarillo. All right. Well, we're 1 hour. Feel free if you have any last minute questions. I am happy to answer them. And okay, here's another one. If we're going to eventually get it, Danielle McGuire, is it worth it to try, given how much freedom we will have if we survive it? Or is it the dumbest thing you've already heard today? No, it's not dumb. I think about this all the time, guys, right? I think about, should I try and expose myself? And, there's the whole topic of variolation. Variolation is like smallpox, right? When the smallpox vaccine, you were actually administering small amounts of the smallpox virus. But if you do it at very low dosages, very low, it leads to immunity. But some people died from that as well. But this wouldn't be that necessarily, at least in the near term. Something I wrestle with, but I don't think when you kind of step back that it's worth it right now. I don't think you purposefully try and get it. I don't think you act haphazardly, because there's too many secondary consequences that we don't know about. There's too many secondary effects, downstream effects, that we can't predict from it. So I'm going to sit tight, and I'll reemerge when things are absolutely necessary, right? If, as far as, do things that I'm just required to do, but I'm in no rush to go to a public baseball game. Obviously go shopping and do the things you need to do to sustain. But it's a really tough decision. It's hard, but you got to do the right thing here. Pete McGrath, do you see hand sanitizer dispensers in public areas becoming the ashtrays of the past? Remember how ashtrays used to be in the office buildings? Yeah. So absolutely, hand sanitizers. I mean, I think, right, I was in New York City on March 7th. It's when I did my first posting, actually, or first video. And right, I was in a hotel, and all the hotels have the hand sanitizers. And every time there's an outbreak, we put hand sanitizers out, right? Flu epidemics, there's hand sanitizers. I remember, when there was SARS and MERS back in the early 2000s, the hospitals all had their hand sanitizers out. Yeah, I think that will absolutely be a part of it. So yeah. So my dad chimes in. He's the ethical guru here. Why take a chance getting it when you see that it kills? Yeah, absolutely. I do think it's something that I mean, it's probably normal that we're thinking that way, right? It was probably normal that we have the conversation with our minds, with ourselves, and even with others. But I think in the end, it's the smart thing not to do. Okay. Well, I think feel free. Any last minute comments here? I think these are really good, uh, good questions, good insights. You know, take a lot of this information, have discussions with um, with your neighbors, obviously from a distance, from video, from your family. But in the end, everyone, keep talking about. Um, we keep talking about uh, adjusting to this new normal, and the more and more we kind of accept, right, and we accept what this is for what it um, is going to be important. Now we grieve for sure, and we have anger and denial. All of those feelings are going to go through every one of us, and they will be in some different order. Uh, and that's natural. That's expected. And always try and find a silver lining in these things. Let's be pragmatic, but also be opportunistic in the way of how can we spend this time in positive ways. All right. People have made it through a lot worse. And you keep reminding yourself of that. People have made it through a lot worse. That doesn't mean we shouldn't struggle. That doesn't mean we shouldn't be sad and angry. That's totally normal. But it gives us hope. It gives us something to reach for. It gives us kind of that North Star in our, right? It's like that emotional and psychological North Star. We're not going to have a society where there's a bell or a whistle that says this is over. We're not going to have the COVID all clear. It's not going to happen. So let's come up with our own ways to navigate, our own ways to survive, and do it uh, together, but apart, if you know what I mean. So thank you, everyone, and I'll check my calendar here real quick. I'll just confirm. Looks like we could do this again next Tuesday. If you have any questions, feel free to leave comments. If you want to change this up at all, I would really appreciate feedback. This is like the 6th or 7th or 8th one that we've done like this. And unfortunately, it's just me speaking now into a black screen, but me speaking into this camera here and hearing you guys. So and just reading your comments. If there's a better way, if someone knows a better way, or things that you'd like me to talk about or touch on, or things to integrate in, or if this is just right, then we keep it as is. So with that, have a wonderful Tuesday, and we will see you next week. Take it easy.